Hi, this is Bob Harrington from Stanford University on the Heart.org at Medscape Cardiology. Following this year's American College of Cardiology meeting, there's been a lot of buzz on the Heart.org forum around a clinical trial that was presented near the end of the ACC meeting, HEAT-PPCI. How effective are antithrombotic therapies in primary PCI? This was a very interesting trial that was conducted at a single center in Liverpool in the United Kingdom. Took place over about a year and a half or so, or 2 years, from February 2012 to November 2013. They enrolled approximately 1,800 patients from a single center with an ST elevation MI who were due for primary angioplasty, and they randomized them to receive unfractionated heparin or bivalirudin, the direct thrombin inhibitor, as the base anticoagulant, and then allowed the investigators to use GP2B3A, in this case abciximab, as bailout therapy in either of the arms. Primary endpoint was a 28-day composite of major adverse cardiac events. Primary safety endpoint was major bleeding using BARC definitions. Really interesting results. The group of patients treated with unfractionated heparin fared better with regard to MACE at 28 days than the group of patients receiving bivalirudin. Stent thrombosis was markedly reduced in the heparin group versus the bivalirudin arm. And interestingly, and certainly divergent from prior studies, the bleeding results were comparable between the two arms. Needless to say that given data that is different than previously reported data, this catches people's attention. But maybe the thing that caught most people's attention and has generated much of the conversation was the way that the trial was conducted. As I said, it was done at a single center. But interestingly, informed consent was delayed until after the procedure, in which case then a detailed informed consent was undertaken in the patients who had survived. Patients who did not survive, there was the availability of their information through the public death records in the UK. Very interesting way of doing the trial. Very interesting way of dealing with the consent issue in acute care, and I thought that the issue of the trial design and what it means to the practice of acute care cardiology would be a good one to discuss today. So I'm fortunate I have my good friend and colleague Magnus Ohman, professor of medicine and director of the Advanced Coronary Disease Program at Duke University and Duke University Medical Center, joining me here today. So welcome, Magnus.
Thank you, Bob. It's great to be here on the other coast of the country.
Yeah, it's reminiscent of the many days you and I spent in the evenings talking about clinical trial results. But in that situation, we had our offices right next door to each other for many years. So this will be a little bit different. Well, Magnus, I've described the trial results. You and I certainly talked about this when we saw each other at the college meetings. This is a fascinating trial. Fascinating from a design perspective, fascinating from a results perspective, and I think really important in terms of the methodology that was employed to do the study.
Yeah,
you want to give your overall comments, and then maybe we'll hone in on some of the specific issues.
Yeah, so I think this is an interesting trial. I mean, we usually never see single-center clinical trials of 2,500 patients. I mean, it's remarkable. And the investigators should be congratulated for conducting, I think, overall, a very interesting and very well-conducted trial. There are aspects to this trial, as you already pointed out, that are different. But the bottom line here, from my vantage point, is it's terrific to see centers do things like this. And sometimes one wishes we could do more of this. But there is a little bit of an issue.
That was certainly my initial reaction, Magnus. I too compliment the investigators, the lead investigator, somebody well known in cardiology clinical trials, Rod Staples. It was a well-designed, well-considered study. And I was blown away by seeing almost 2,000 patients enrolled consecutively from a single center.
Yeah, it's remarkable and well done. I mean, they did practically enroll every single patient. I mean, they had some minor exclusion criteria, but in general, they enrolled just about every patient, which is a great way of finding out how the therapy works in your setting. Now, the larger question is, what's the implication of this trial vis-a-vis other trials that have been done, heparin versus bivalirudin? And let's leave out the Horizons trial for a little bit, because there has been some, at least in elective PCI. This is not the first trial that has been carried out comparing heparin and bivalirudin. You were, in fact, Bob, I think you were involved in some of the very earliest trial. So there is a sort of an interesting history here. We've been using bivalirudin for PCI, not necessarily for STEMI PCI, but for non-STEMI or stable angina. We've used these heparin and bivalirudin for many years. It wasn't approved initially, but they were studied very carefully. And those early trials were interesting because they came with a message. And remember, we didn't have glycoprotein 2B3 receptor blockers with the first few trials.
No, the first trials, going back to the Biddle trial, it was without. It was in the very early days of really intense studying of antithrombotic therapy in the cath lab.
Right, but in those early trials, even in those early trials, there was a signal to lowering bleeding. And then, in fact, there was a meta-analysis now published a couple of years ago by Michel Bertrand and others that have taken all these early small trials and other smaller trials from all over the world, and they've also found this consistent message of lowering bleeding. They didn't find a consistent message in a reduction of ischemic events, but what they did find was that, it was a little bit above, a little bit below the line, if you understand what I mean. But it was because the trials were small, the confidence intervals were very wide.
Right.
So here, what's interesting with this trial is that the bleeding signal is not what you'd expect, maybe. At least my take, or initial take here.
That was my initial first take as well. I mean, the ischemic difference, again, let's not yet focus on Horizons, but if we look at many of the earlier trials with bivalirudin versus a strategy, I'll say, of heparin plus 2B3A, there has been this suggestion that there's an early ischemic benefit with the heparin plus the potent platelet inhibitor. Over time, some of that is attenuated, but the big difference comes in the bleeding results. And then we've got the Horizons trial, which is very different than these results.
Yes, but once again, that's against a glycoprotein 2B3 receptor blocker. So some of the interesting aspects of this trial is, of course, it's STEMI. So while patients were quote unquote preloaded, really don't know how much of the drug, of either clopidogrel, prasugrel, or ticagrelor actually got into.
A lot of ticagrelor used in the study, yeah.
Yeah. But generally speaking, we don't have, for these very rapid primary PCI trials, I really don't know how much of this therapy gets absorbed. You probably saw this paper in JACC published a couple of weeks ago from a group who have looked at the absorption now on platelet function with clopidogrel in the acute setting and noticed that they could almost correlate it to the amount of morphine given. And we know morphine reduces gastric uptake or gastric mobility and therefore reduces uptake. So this is an interesting area. So this trial is interesting from a lot of different perspectives, and that it sort of sheds interesting light on an area that we thought we had resolved, but like most other things, we don't really resolve things. We get to a point and then we have some interesting information that sort of puts us back saying, okay, why do we see this?
Right, and how should we think about it, and how do we interpret this in light of previous evidence? Are there issues here that we need to sort of, pull apart and think about why it might be different? And then ultimately the questions always ask, what do we do with the data? So let's sort of start on the methods here, Magnus. Single center. You and I have both pointed out that we are impressed and congratulate the investigators for their commitment to pulling this off. But there's an other side of single-center clinical trials, which is the generalizability. Is the generalizability better here, Magnus, because they enrolled such a big sample of patients?
It is to some extent, but we talked a little bit here earlier about the two arms, and they measured ACT in both arms, and they were lower. Now, they used a very different methodology for measuring ACT in this study compared to other studies. They use, I think, a device that we don't actually have in this country, but I could be wrong with that. But that is one of these things that goes to generalizability, namely, if you have just one piece that very few other centers use, what does that really mean then? Does that mean the same thing, or is it means that there's something here that may not be quite right? What was interesting here, and I didn't see this in the slides, but they did mention that they had to rebolus some patients. Now, in generally speaking, at least at Duke, and I'm sure it's the same at Stanford, it is quite rare for us to rebolus patients with bivalirudin.
Yeah, and in the clinical trials, it was very unusual. When we did the early clinical trials that were, double-blinded, et cetera, trials like Replace, repeat dosing was unusual.
Right. So maybe there is something here. I don't know. I don't want to sort of say that this is the reason the trial is totally flawed. But it gets back to the fact that if few centers use this way of methodology for actually examining the effectiveness of the anticoagulation, then that's hard then to interpret in your own setting because you don't use the same device. And so what does this really mean? So on the heparin side, which I think we know fairly well, so the heparin side, the ACT levels were about 200, 220 thereabouts. That's kind of low if you're using single heparin. I mean, David Moliterno's paper many years ago, he pushed that over 250, and there's been some really beautiful analysis done by David and others from Cleveland Clinic just looking at where is the optimal range for heparin. Well, it's over 250. Now, is it the device or are they underdosed? I don't know. I mean, I really don't know.
Right, and as you know, and certainly in modern angioplasty, including fresh elevation MI, the speed with which these procedures are done is very rapid. Once you get access, once you get a wire across the lesion, things go very quickly. And, a lot of those studies that looked at the relationship between ACT and outcome were in an era where the procedures were, frankly, a lot longer. And if you get in there and you get out pretty quickly, how much antithrombotic effect do you need? I mean, do you need to have the level that we used to think about years ago when we were trying to prevent things like abrupt closure? Certainly now we're in and out pretty quickly.
Yeah, I mean, most of these procedures, I think even in this trial, lasted less than 25 minutes, as I recall.
Yeah, and if you look at even the ACS trials, some of the recent PCI trials, things like the Champion studies that both of us were involved with, those procedures had a median time of 20 minutes. I mean, obviously a little bit different with ST elevation MI, but the point is these things are going quickly. Well, Magnus, let's turn the attention to the consent issue, because to me that is one of the most methodologically interesting things that they did here. They got countrywide consent through the UK ethics boards, and then they delayed actual consent from the individual patient until after the procedure. People have talked about this, and in some settings, CPR, for example, trauma, the notion of community consent has certainly been something that's been accepted in the clinical research community. But in acute MI research, we've largely still relied upon individual patient consent before the procedure. This is a very different place, and I got to tell you, I liked it a lot. I think it was innovative. It was bold. They did it what appears to be very carefully. And, boy, if you want to do acute MI research, isn't this the way to go?
Well, so here I differ, Bob, because I served on the Duke IRB for nearly a decade. And I have to say that, yes, they did all the right things if this was resuscitation research, if this was out-of-hospital cardiac arrest research, for example. That's what you have to do to go through a central IRB that sort of in a community forum that actually discusses the trial in the community. And I think they did all the right things. But
so you have no problem with the ethics of the trial?
I have to some extent some ethical dilemma here, and I'll come back to that in a second. But let me just go back a little bit in time, because it's always helpful to look back. So the ISIS-1 and ISIS-2 trials were both large randomized trial mortality trials, both run out of Oxford. They were done with only verbal consent. That is to say, the patient, you documented in the chart that the patient had been verbally consented for the trial. And, of course, that wouldn't hold much, but that's what was done back then. And to some extent, I think some countries may have had no informed consent. But I think in today's society and how we think about things, if you can get consent, and I think you can get consent in AMI. You can't get it in resuscitation or unconscious patient. I fully accept that. But when you can get informed consent, and I understand the leeway here is what does the word informed mean here. But
right.
I think, just like you're describing, I'm about to take you, the patient, to a cath lab, do a cardiac catheterization. There's some risks and some benefits. That's what we say to our patients right now. They sign a piece of paper and we do the procedure. That's standard of care. I do not believe that you couldn't actually add an informed consent to that part, namely telling the patient the same thing, making them understand that there's two options for anticoagulant, and we don't really know which is best, and here is the study outline, and then have them sign. Now, in many settings, you can do an abbreviated informed consent that's just one page, just like a consent for
which has been utilized in acute MI research for a long time, as we both have employed it. But Magnus, let me take a different view here. That in the practice of medicine, doctors do all sorts of things, sometimes without a lot of rhyme or reason to it. It's the practice pattern. It's what they feel comfortable with. It's what they've done before. And so the practice of medicine, in many ways, as you and I know, is fairly random. And, when you're asking a question around commonly used drugs that the doctors are going to use anyways, isn't in many ways a more ethical way to practice is to actually try to learn something from it. In fact, there's been a great series of papers coming out from the Hopkins group, published first in a Hastings Center report that says, why wouldn't you incorporate learning into the system in a very, in a more formal way than we currently do? And maybe this is the kind of clinical trial that starts to fit the construct of the so-called learning healthcare system, where you take two things that are commonly done, and instead of letting the doctors pick, you randomly assign, so then you have the scientific ability to compare A versus B.
I think that's a reasonable thing on one level. On another level, if you're a patient, you expect us, you and me, as doctors, to pick the best treatment that we think is best for that patient. Now, you're right. We could actually say, Mr. Jones, I'm clueless of what to do. But that's not how we practice medicine today. We basically do make, and they might be random. They might be random for all that we know. And I think there's good data sometimes to even suggest that. But we're supposed to take the best tack for the patient in the individual setting. And so my thinking is that's a little bit of a leap to go on and say, well, I'm going to show up and say, we're going to do this procedure, primary PCI, but I have no clue what to do. I think the next...
Yeah, I'm not saying it's quite that stark. I'm saying that in this setting you have drugs that are widely used. There is random variation in how people use them. Why not try to learn something in the system I actually really like this idea of delayed informed consent in this particular setting for a trial like this. Now, where I wouldn't be as in favor of it, if you said to me that there was a brand new procedure that nobody knew how it worked, or a brand new drug that nobody knew how it worked, I would have a different perspective. But in a setting like this where you knew pretty much the characteristics of the two therapies, but you want to see how they perform head-to-head as was described, I got to tell you, I liked the approach that they took. And to me, it fits with the ability to do. You and I both said at the outset, we like the idea of a center enrolling all of their patients into a clinical trial. Why not make it easy for them?
Well, I'm all about making it easier. I still think we should be honest when we make an experimentation, and that's where I come down on it. It differs from your point of view, but I think the world is sort of split.
Well, that's why it's good to have the discussion, because I have a sense that a lot of medical practice in some way is experimental, but we don't learn from it because we don't have an ability to make inference when things in this particular example, when they're not randomly assigned. So it is challenging because there's, as you and I have done a lot of clinical research, we certainly don't want to return to an era when human experiments were done in secret and patients and other vulnerable individuals were trust was misused, et cetera. I'm certainly by no means recommending a return to that, but rather just an opportunity to think differently about how we might do clinical investigation in some settings.
Well, and I would, the sort of aspect of this that I think is really key here is that clearly in this setting in Liverpool there was equipoise. That is to say, because they had to have that in order to go. In order to
randomize the patients, there had to be equipoise.
Right. So when we have equipoise or questions, we should try to answer those questions, and they set out to do that, and they have their answer for their practice of medicine and their setting. There is no doubt about that, and it goes back to generalizability. How can we generalize this to other settings and so on? And that's harder to do, and there's always some of that. So that's why I think the power of a good multi-center clinical trial, to me, is so powerful, and that, as you know, goes on and actually defines guidelines in this country, pretty much. I mean, one aspect is approval for the FDA, but the other part is also it helps us to inform the guidelines so we pick the best treatment for most of our patients. And I wish more people would do this.
Yeah, so this has been exactly the kind of discussion that I wanted to have, Magnus, and I appreciate you joining me. It's the topic's a tough one, and I hope we get some conversation going in the broader community about how one does think about studies like this. I think we both agree that these investigators should be congratulated for undertaking that. We're both intrigued by the outcome results, which are different than some of the previous studies, and we're both intrigued but differ in our interpretation of the way that the trial was done from a consent perspective. Is that a fair summary?
I think that's a great summary.
Magnus, thanks for joining me here on the Heart.org and Medscape Cardiology. This has been a discussion of the HEAT primary PCI study out of Liverpool, UK. My guest tonight has been Magnus Ohman, professor of medicine at Duke University. Magnus, thanks again for joining us.
Thank you, Bob. It was fun. Thank you.